Thank you for joining me today. Today we're going to look at a Repatha denial and answer some questions about why in certain cases we can simply just get something approved without any additional information, and while in similar situations that some people think are exactly the same, we can't really do anything about. And that's what today's example is. Today is an example of a situation where there was really nothing that we could do, but it's very similar to other situations where we can simply just get it overturned without any additional problem. And what we plan on doing at the end is showing how very small changes in the case situation can cause one pathway to be cheaper than another, or more administratively effective is the terminology that I like to use. And remember, what our goal is to take all this pharmacy paperwork and figure out how to deal with it in the cheapest way possible. And by the end of this video, you're going to understand why this is the cheapest way of dealing with this issue. In this example, we have two denial reasons. Number one, we need an LDL greater than or equal to 70 within the past 90 days. Secondly, we need a trial of a high-intensity statin in combination with Zetia, or a reason they couldn't use it. The facts of the case are, number one, the LDL could not be calculated. This is due to the fact that the triglycerides are over 400. Their most recent lab would have been in date. However, they had triglycerides of over 1,000, therefore it could not be calculated. Secondly, they're on a high-intensity statin with rosuvastatin 20 milligrams. However, they are not currently on ezetimibe. Lastly, their LDL goal is 55 milligrams a deciliter. What's on that screenshot there is that they're a diabetic with a history of revascularization procedure, and per the diabetic endocrinology guidelines, they would be considered extreme risk, and they would recommend less than 55. So that's not a problem. The ezetimibe is not a problem, assuming that we can get a calculated LDL. If it's implausible that they would be able to get to their goal of less than 55, or even if we wanted to use their goal, less than 70, then that would be unreasonable for them to try. So our main problem here is that we don't have an LDL. So we could have the patient go do a direct LDL, or there's another way to solve this problem some of the time. We'll talk about that on the next slide. Whether or not we can appeal this or not is really going to come down to whether we can get that calculated LDL. So the reason that we can do it some of the time and not others is due to two different equations. So the first equation is the Ferdinand equation. I hope I'm pronouncing that correctly. And this is the standard equation that is used by most labs that do a calculated LDL. The LDL is equal to the total cholesterol minus the CHDL minus triglycerides divided by 5. And it is effective up to 400 milligrams per deciliter. That's where that comes from. There is, however, another equation that you can use called the Sampson equation, and this is more accurate, and it is effective up to 800 milligrams per deciliter. So assuming the triglyceride level is, let's say, 500, 600, or 700, as long as we have all of these variables here, the total cholesterol, HDL, triglycerides, and non-HDL, then we can simply just recalculate it, and now we have a calculated LDL. Once we have a calculated LDL, we can then determine whether or not we need to meet our ezetimibe criteria, and then from there we can simply determine if we can appeal or not. In most of the cases, we're going to be able to do that appeal. Now that you have a little bit of background about this specific case and the different tools that we can use to try to get things overturned, you'll be able to better understand our recommendations. So for this case, we're going to recommend to not appeal and to perform a direct LDL. The reason is that the Sampson equation would not be able to give us that calculated LDL. As you recall from the beginning, the triglycerides were over 1,100. Now, if that were the only reason that it was denied, we would change the recommendation to appeal. The reason is that in this case, since the LDL goal is 55 and the total cholesterol is 260, or let's say if you had a situation where it's even higher than that, there is a distribution curve on that study where it would be highly implausible that their LDL would be under 55 or under 70. So there's some other math that you can do and basically make an argument. We don't know what the LDL is, but based on these distribution curves, we could estimate that it is likely to be more than this number, and that's really what it's about. However, in this case where we've got not only got the LDL but then ezetimibe, well, now you'd be doing an estimate of an estimate, and once you start getting into that situation, then your approval rate, let's say for the boilerplate argument where we don't know what the LDL is and we're using a distribution curve, that would probably be about 70%. But once you're doing the estimate of the estimate, it'd probably be 30 to 40%. And that's probably too low for it to be administratively effective. So what we recommend here is to perform the direct LDL. We only recommend that you would consider ezetimibe is in two situations. If the patient will take too long to get back to you. So if they're going to take 6 months to get back, you may as well send it in. Or if it's conceivable that the ezetimibe could get them to goal. So if their LDL comes back as 60 and the goal is 55, well, they're probably going to need to try that in most cases. So the reason that we don't recommend to try it in other situations is because if it's not conceivable that it could get them to goal, let's say their LDL comes back as 150 and the goal is 55, there's no way that they're going to be able to get there. And in those situations, it's going to be overturned 99% of the time. The only time it's not going to be overturned is people who are being unreasonable. The reason for the administrative effectiveness is that if you send this for the patient to try it, you've got to send the prescription. Sometimes you got to send it to a certain pharmacy. You got to call the patient. They might have questions about the drug, so you have to spend time doing that. And once it gets to the pharmacy, it could possibly need a prior auth. It doesn't need a prior auth that often anymore, but we do get them from time to time, probably about 10-ish% of the time. Even if it doesn't need a prior auth, a lot of times this is on a tier 3 or it's even more expensive, which is about $50 on a lot of plans, probably about 40% of the time. Which means that they might ask you to do a tier exception, or they might say that I'm not going to pay for that, in which case now you're going back to the appeal that you should have sent the first time anyway. Even if they decide to use a discount card, for example, well, now that you have to give them a discount card, and at some pharmacies where it's more expensive, such as Walgreens, those discount cards might still take it down to $40, in which case you're not really saving them that much money. You're talking to the patient multiple times. You probably made 3 or 4 phone calls by this amount of time. That's way more expensive than doing an appeal. An appeal is, a 5-minute phone call. That's what it costs. All right, that's the approximate cost. So assuming that has been sorted out, they did get it cash, then you need to get that claims data, because if you go and do another prior auth, they're going to say, well, you said they took Zetia, but I don't see any claims data. A lot of them will do that. So now you need to get the claims data from the pharmacy. And if you're using a CVS or a Publix or a Walmart, it shouldn't be a problem. But again, some pharmacies, such as Walgreens, for example, and you'll know this if you've worked with us for a long time, they won't give you that information. So now you got to call a patient and tell them to tell Walgreens to give them the information, or tell them that it's okay for them to fax the information to us. Now we have all this information. Now we can submit this PA again and hopefully get it overturned on PA. But of course, if there's any problem along that process, then we've got to do another appeal, which is what we were going to do anyway. And of course, in the middle of that process, once they've taken ezetimibe, they might need to get another lab showing that their LDL is still too high with the ezetimibe. So you can see the amount of time that could be spent pursuing that process, where if you just send the appeal and make the right argument, it's going to be overturned 99% of the time anyway. So that's why the recommendation for this would be to appeal and to only take to only do the ezetimibe if it takes too long and it's not really going to make much of a difference for you, or if it's conceivable that it could get them to goal. Before I go here, I want to give you one more example of how a very small subtlety can change what makes most administrative sense and can save you an insane amount of money. For example, if we had the exact same denial reasons on the exact same case, the LDL and the ezetimibe, if it was denied for one more reason, which was Praluent, it completely changes what makes the most sense to do. If it's also denied for Praluent, what you want to do is nothing what we recommended. You don't want to send for another lab. You don't want to send ezetimibe. You don't want to do any of those things. You don't want to appeal it either. What you want to do is send for patient assistance. And the reason for that is if you change to Praluent, you still need to get the lab. You still may possibly need to try ezetimibe, and you'll still have the same problems, right? You're going to spend all this time dealing with the lab, explaining to the patient about the change in drug, dealing with the pharmacy, with ezetimibe, and then you need to do another PA, possibly another appeal, and of course, even after that, it may not be affordable to them. So you may need to file for patient assistance anyway through a different company, right? And or file for a grant or copay assistance. And then many times, especially on Medicaid plans, for example, I know at least in our state, the initial approval is only for 3 months, which means you need to do another PA and you need to get another LDL lab showing that there's a reduction. And then you have to deal possibly with a specialty pharmacy, and then you got to send it over there. Whereas if you had just sent it to patient assistance, then you wouldn't need to do any of that. You simply send it to patient assistance. You don't need to worry about PAs. You don't need to worry about the lab. You don't need to worry about sending scripts to pharmacies. You don't need to worry about the cost. And the reason you can do that is because that patient assistance program, at least while I'm making this video currently, it can't change at any time. That patient assistance program, if the reason it's denied is due to trial and failure of their competitor's product, they'll let you in for that reason. So by simply applying to patient assistance, you probably saved about $80 to $90 of just calling labs, getting labs, processing labs, talking to patients, talking to pharmacies, talking to insurance, dealing with appeals, dealing with high copays, redoing prior auths, getting new labs. You saved so much money by doing that. So a very small subtlety can change massively how much administrative burden you are spending at your practice. And that's basically what we do for you. You don't need to know all of this stuff. You simply send the request to us and we'll find the most administratively effective way of dealing with it for your practice given your specific parameters. Thank you for joining me again. If you have any questions, feel free to give us a call, send us an email, or just add a comment here on YouTube and I'll be happy to get back to you. Thank you for watching and I'll see you around.